Cash USMLE style question on graft versus host disease, GVHD. Question: a 42-year-old man with acute myeloid leukemia, AML, undergoes an allogeneic bone marrow transplant from an HLA-matched sibling donor. 3 weeks later, he develops a maculopapular rash on his palms and soles, along with profuse watery diarrhea and abnormal liver function tests. A skin biopsy reveals lymphocytic infiltration with apoptotic keratinocytes. Which of the following best describes the underlying pathophysiology of this patient's condition? A. Recipient T cells attack donor-derived hematopoietic stem cells. B. Donor T cells attack recipient tissues, targeting HLA antigens. C. Preformed recipient antibodies against donor HLA antigens activate complement. D. Activation of host macrophages leading to cytokine storm. E. IgE-mediated mast cell degranulation causing widespread tissue damage. B. Donor T cells attack recipient tissues, targeting HLA antigens. Explanation: this patient has graft versus host disease, GVHD, a serious complication of allogeneic bone marrow transplantation. The key features include maculopapular rash, especially on palms and soles, watery diarrhea, GI involvement, liver dysfunction, elevated LFTs, jaundice, histology, lymphocytic infiltration with apoptotic keratinocytes. This occurs because donor T cells recognize recipient tissues as foreign and launch an immune attack. The main targets are skin, GI tract, and liver. Pathophysiology of GVHD. 1. Allogeneic bone marrow transplant contains mature donor T cells. 2. These T cells recognize recipient HLA antigens as non-self and mount an immune response. 3. Inflammatory cytokines, IL-2, IFN-GUA, TNF-A, amplify tissue damage. 4. Affected organs, skin, maculopapular rash with epidermal apoptosis, GI tract, watery diarrhea, mucosal ulceration, liver, elevated LFTs, jaundice, hepatocyte apoptosis. Match: types of GVHD, timing, symptoms, mechanism. Acute GVHD, within 100 days post-transplant, rash, diarrhea, liver dysfunction. Donor T cells attack recipient tissues. After 100 days, fibrosis, dry eyes, oral ulcers, skin thickening, autoimmune-like chronic inflammation. Why not the other options? A. Recipient T cells attack donor-derived hematopoietic stem cells. This would cause graft failure rather than GVHD. GVHD is caused by donor T cells attacking the recipient, not the other way around. C. Performed recipient antibodies against donor HLA antigens activate complement shots. Describes hyperacute rejection seen in solid organ transplants, not bone marrow transplants. D. Activation of host macrophages leading to cytokine storm. Describes hemophagocytic lymphohistiocytosis, HLH, or sepsis, not GVHD. E. IgE-mediated mast cell degranulation causing widespread tissue damage. This is type 1 hypersensitivity, e.g. anaphylaxis, allergies, which is not involved in GVHD. Key takeaways for USMLE. GVHD equals donor T cells attack recipient tissues, skin, GI, liver. Occurs after allogeneic bone marrow or stem cell transplant. Acute GVHD, rash, diarrhea, liver dysfunction 100 days. Chronic GVHD, fibrosis, dry eyes, skin sclerosis 100 days. Treatment: immunosuppression, cyclosporine, methotrexate, corticosteroids. Would you like another question?